Go ahead and just get started with introductions, and I can start. So I'm Jason Herndon. I'm a licensed psychologist, and I'll be the moderator of today's panel. I am the clinic director at the graduate training clinic here at UNC Greensboro. And so I'll let some of our other presenters introduce themselves as well. CR, why don't you start us off?
Sure, I'm CR Macchi, licensed marriage and family therapist. I'm with the College of Health Solutions and the Doctor of Behavioral Health program at ASU. I'm the associate chair of the internship programs for the integrated behavioral health area.
Okay. Stacy?
Sure. My name is Stacy Obeid, and I'm a health psychologist and faculty here with UT Health in San Antonio, Texas, in the Long School of Medicine. I am faculty in the family medicine residency and psychology residency program, as well as kind of curriculum designer for our, we have a HRSA grant with the University of Texas, San Antonio's master's program in clinical mental health counseling. So I help co-develop that integrated behavioral health certificate program for the master's students.
Florencia?
Hi, I'm Florencia Lebensohn-Chi. I know it's a mouthful. I am an assistant professor at the University of San Diego in the Department of Counseling and Marital and Family Therapy, but I am myself a licensed clinical psychologist. I also hold a voluntary assistant clinical professor position in the Department of Family Medicine and Public Health here at the University of California, San Diego. I also serve as the project director for a HRSA grant as well that has different emphasis, but one of them is integrated behavioral health and the training of a behavioral health workforce.
Great, thank you very much. So we thought what might be useful is to go ahead and get started by talking a little bit about what are each of the individual sites that you are working at, and tell us a little bit about how it is that you are approaching graduate education there and with whom. Oh, why don't we start with Stacy?
Sure. So one of the things that we're doing within our HRSA grant program is we design an integrated behavioral health certificate program for students who are interested in working in primary care with underserved communities. The master's program here at UT already had a bilingual certificate program, given our patient demographics here in San Antonio, Texas. And so we wanted to offer an additional certificate program for students to receive additional training in primary care. And so what that involves is they take 2 3-credit-hour courses that the first course is focused more on foundational principles of what is primary care, how does behavioral health fit into primary care, really a primary care primer, so to speak. And then their second course they take is more of a primary care assessment and interventions course. So how do I function as, and we focus on training them on, in the second course within the primary care behavioral health consultant approach. So how do I function as a BHC in primary care? So they learn how to do functional assessments, sexual interviews, and brief interventions within the primary care setting. During their last 2 semesters in their master's program, they complete a clinical internship in a primary care setting. We have them in rural settings outside and inside of Bexar County in Texas, as well as women's health, family medicine, internal medicine, and they are placed there. And during the second course, they're concurrently enrolled in their first semester of the internship. And so they really get to try these brief interventions and assessments that they're learning in the course on their internship site. So by the second semester of their internship, they are feeling much more confident, building self-efficacy, and using the skills that they're learning to function as clinicians in primary care. So that's a little bit about, I don't know how much more you want, but I'll stop.
No, I think that's a good start. And I should say that we can either do, we have some time saved for questions at the end, but if anyone has any sort of specific questions, I think we have a little bit of time if you want to ask them right away. So why don't we sort of jump next to Florencia and have you tell us a little bit about how you're approaching graduate training in your specific setting?
Sure. So we primarily work with our MFT trainees when it comes to integrated primary care training. So for a while now, probably about 15 years or so, we've had an ongoing partnership between University of San Diego and University of California, San Diego Department of Family Medicine. And so through that, what we've done is we haven't had as much luck in terms of trying to develop a certificate program, but I'm very intrigued and curious about trying to do that in the future. So what we do is we have a standalone required course that all of our students take. And we think of it as like an introduction to integrated behavioral health more broadly. And we focus a lot on primary care, but talk a bit too about specialty care. And so all of our students are required to take that course. Recently through the grant, we've been able to, our HRSA grant, we've been able to add a case simulation component. So once a year, what we do is we take our MFT students that are enrolled in that course, and we partner with our nursing school, and we've created an interprofessional education experience for them, where we really try to simulate kind of a day in an integrated primary care clinic. So that's been really exciting. We've done that now for 2 years, and the students have been just really thrilled with the opportunity to take what they learn in the course and then immediately apply it in a kind of a simulated environment where they're safe to make as many mistakes as they need to in order to learn the material. And in terms of practicum placements, we currently, it ebbs and flows, but we typically have on average between 6 and 8 students in a cohort of, about 28 that we're able to place at an integrated care site. And so that includes, so they're really sought after sites, the slots, but that's during their practicum year. We have students that we place in family medicine, internal medicine, pediatrics, reproductive medicine over at UCSD. And then this year we'll be starting to experiment with some of our local FQHCs. And so we hope to be able to offer more integrated primary care and specialty care placements for our students moving forward. The other thing we've been able to do, again, through the HRSA, and I know we'll be talking a little bit about financing all of this lovely training. But what we have been able to do is also really try to offer more professional development opportunities for our students that are particularly interested in working in integrated care. So for the last 2 years now, and we have our new kind of group we'll be taking this year, we've been taking a group of students to CFHA. And some of our students go and they're placed in primary care, others are placed in other practicum sites, and just have a really kind of a growing interest in entering integrated primary care post-graduation. And they've been thrilled with that. They come back really energized and really kind of just enjoy seeing what the professional community looks like and what could be possible moving forward. We also, through the grant, have an ongoing seminar series that we offer. So these are kind of like a lunch bag series that we offer during the lunch hour once a month. And many times those topics, we bring in speakers from outside and focus a lot on integrated behavioral health topics. I'll stop there, and then if there's any specific questions, I'm happy to answer them.
Okay, well, great, thank you. CR?
So we have, our program is a doctoral level program. We have 2 concentrations, one clinical, the other management. Both concentrations really embrace the idea coming out of C.J. Peek's work, where he talked about the interdependence of the 3 worlds of healthcare delivery, and that's clinical, operational, financial. So the clinical students are not only learning clinical skills to operate effectively in primary care, but also all the management related issues and financial issues, and vice versa for the management students. Our clinical program prepares students, assuming, first of all, they have to have a master's in some type of field that has laid the foundation for doing clinical work. So the typical, especially mental health disciplines, and as well as like OT. We also have had nurses, pharmacists, PAs, and others who have a clinical foundation, and then we're building upon that foundation by adding layers of training that helps them to work specifically in primary care in a brief, targeted fashion, as well as training them on team-based skills. And for those who come from specialty mental health, really putting an emphasis on the difference between the culture of specialty mental health and medicine. By the time they get to their internship, it's in a medical environment where there's both medical and behavioral provided. And they know going into that experience, which is a 2-semester experience, that it needs to be an environment that has both operating, and that their preceptor on site is someone with a medical degree. And the purpose for that is that we really want to make sure that they engage fully and are guided by someone from the medical field to help them make the jump from thinking through a mental health lens to really thinking more broadly through a behavioral health lens, and one that is that works appropriately within a primary care environment. On the management side, we have students also who come in with a master's, usually from business, and they're interested in refining their skills to really focus on healthcare administration, healthcare management, practice transformation, all with the emphasis on how that would occur around issues of integrated medical and behavioral healthcare. They typically, their internships are with payers, with ACOs, with large health systems. Some are with primary care or family medicine clinics, and all those. Because our program is online, all those are across the United States. We place approximately 50 to 70 students every semester. So it's a lot of students, a lot of placements. Part of and this is for our own model, part of the training for them is really the pre-internship phase is a critical phase where they're actually, as you can imagine, we have a list of, I don't know, about 350 sites on our list right now where students have been. But there are students, since we draw from all over the US and even in different countries, there are students who are in areas where there's never been an intern. So part of the pre-internship is really helping them to think about how do they understand and articulate what their role is as a DBH intern, and how do they make contact with those sites, develop those relationships, really take all the steps necessary to establish both a mutual understanding between them and the site of how they could join in the clinical side, join the medical team on the management side, join the management team on site, usually the C-suite folks, to really join them in their work, help them to accomplish their strategic objectives, and use the internship to support those while they're there. There are a lot of other things to say as well, but I'll stop.
Okay, great. Hi, Victoria. It's good to see you. Will you introduce yourself to the group and then talk a little bit about how you're approaching graduate education in your specific setting?
You might have to unmute her on your end.
Oh. Oh, I don't seem to have the ability to unmute. Victoria, are you unmuted?
Yes, I am now.
Hi.
Hi, sorry about that.
No problem. Will you let us know, just sort of introduce yourself and then talk to us about sort of how you're approaching graduate education in your site?
Yeah, sorry, I'm coming in late though. I don't want to disturb the process.
No problem.
You sure?
Yep.
Okay, so I'm Victoria Soltis-Jarrett. I'm a psych nurse practitioner and I'm also a professor at UNC Chapel Hill School of Nursing. And my role right now has been probably for the past probably 10 to 12 years is developing a behavioral health integration program for both psych nurse practitioners and for family and adult gero nurse practitioners in primary care.
Great. And so what are some of the sort of things that you're doing in terms of your approach to graduate education with your students?
Well, I guess with the first project that I had, everything that I've had to do with funding. So probably the first and foremost thing was to get funding for any curricular changes, clinical sites, etc. So the first grant really looked at embedding psych nurse practitioners in acute care, primary care, and long-term care settings. And then the second grant really was to test the model that was developed for nurse practitioners to learn about behavioral health integration. That grant just actually finished up. And then the most recent grants, I just was funded to continue to expand and partner with FQHCs and to work with, again, a curriculum and the clinical placements. And then I also have a nurse practitioner residency program.
Okay. And so just sort of so people are aware, are the folks that you are training, do they have any exposure sort of prior getting to your projects with integrated primary care? Or is that also a part of what you're doing, sort of orienting them to that process, that work?
So in general, as you're all aware, I'm sure that some of the students that we have actually do come in as second degree or postmasters. Mm-hmm. So some do come with experience, but mainly it's been by the seat of their pants. So they may be someone who has worked in primary care and had to manage some of the behavioral health and substance use disorders. And so they do come with, how I look at it is, they've learned things, but sometimes they have to unlearn them and learn best practice. And so that's kind of what I've seen. And then I have what I call sort of the tabula rasa people, which have no experience. And I'm really getting them from the very beginning.
Great. Thank you so much. Oh, sorry.
Do you want us to make comments? Because I really...
Sure.
Yeah, Victoria, I appreciate that comment you made, the unlearning process. We find that with our clinical students who come from specialty mental health, they're really focused on diagnosis of a mental health condition and focusing on those outcomes. And one thing that I noticed that our students on the clinical side, the challenge for them is really making the shift. If I'm joining a medical team, how can I also embrace the medical outcomes that medical team has on their horizon and in their sites that they're targeting, and bring my specialization in behavioral health to assist them to get there with those patients. That shift is a critical shift for them conceptually, I think.
Mm-hmm. How do you sort of help them manage that shift, CR?
Well, one thing, we try to interweave that in all of our curriculum to constantly remind them about that. As the internship chair, I meet with students prior to being placed, and I help them think through how would they articulate what they're going to do on site before they actually approach a site. And I listen for that. I listen for if they've made that shift. And so we have a real conversation about that. By the time they get to the site and they start talking with the site contacts, the folks they're going to be working with, they begin to really hone in on that articulation. And then the faculty who are assigned to all the students during their internship continually reinforce it so they can make that shift. And then we have metrics that we monitor that help us to identify while they're on internship that adjustment's being made as well.
Okay. Stacy or Florencia, is this also sort of an issue that you run into with this sort of working with people to sort of unlearn sort of previously learned sort of skills or styles of doing or styles of thinking more often is what it sounds like?
Yeah, Stacy.
Oh, Stacy, you go.
Go ahead.
No, you go. I'll go last.
Okay. Yes, definitely. I'm in an interesting situation because I'm getting students who are on the tail end of their master's program, and so they're still moldable, which is nice. They've gone through practicum, learning traditional psychotherapy and counseling skills and interventions, which is useful and helpful. And so the unlearning isn't as petrifying for them as, say, if I have somebody who had been in practice for 15, 20 years doing traditional outpatient mental health and coming into primary care. When I train doctoral students or I train our psychology residents, for those who are new to primary care, it's a bit shell-shocked, so to speak, and a steep learning curve, but they're still in that moldable phase in a sense because they are still trainees, so there is a lot of room for unlearning unhelpful behaviors for primary care.
Yeah.
Yeah, I think for us, we're kind of in a similar boat in terms of, our students are sometimes, in the first year of their master's program. I think what ends up being more of a challenge for our master's level MFTs is that they're getting bombarded with so much knowledge, especially in that first year, and they're trying to figure out, what they're interested in and where, what direction they see themselves going in. Is that we often have to try and kind of slow them down a bit, and they kind of feel like they need to make a decision one way or another if this integration thing is something they're going to be interested in, and that they need to specialize right away. And so just most of the time, myself and my colleague, who I should mention, Laura Sudano, I work very closely with her, and we often co-teach the foundations course, is really helping them appreciate how they can take what they're learning in their other classes and what translates when we're talking about integrated behavioral health and what's different about it. And then just making sure that they're staying open and just appreciating this is the time to explore and try things out. And maybe you'll love integration and maybe you'll hate it, but that's okay either way. So that tends to be more of our challenge with our students.
Mm-hmm. Yeah. So let's just sort of keep going with that. I think it dovetails nicely into our next section, which is sort of talking a little bit about sort of what are some of the successes and also what are some of the challenges. And so it sounds like this sort of unlearning process can be one of the challenges depending on where you're getting your trainees in their stage. But what are some other challenges and then, of course, successes that you've had in your efforts to graduate education? Why don't we start with, keep going with Florencia.
Oh, let me. Sorry, I'm struggling with the unmuting and muting.
No problem.
Oh gosh. So I think that for us, when I was thinking about the agenda that you set around, center around, I think in terms of challenges, what's always been a struggle, I think, for our faculty is a couple of them. First is kind of because we are not a program, like the ASU folks where, integration is all we do. We are a generalist program. We are training MFTs more generally to work in all kinds of settings. And so figuring out how can we definitely honor the fact that we're very interested in integration here, and having folks understand what integrated behavioral health is and the value of it, but then balancing that with everything else that we need to cover and give space to in our curriculum. And I think the other one kind of related to that is then figuring out, identifying training sites and building those relationships. We take a lot of pride in making sure that we have longstanding, very strong relationships with our practicum sites, so that we know that they are committed to training and that they're going to do a great job with our students and give them a meaningful experience. And so we cultivating those practicum sites, making sure that their version or approach to integration is congruent with what we're teaching and what we want to make sure our students are exposed to, that takes time. And so, oftentimes we'll be cultivating a site and we'll get right to the, like where we have to make a commitment and then it falls through. And so I think that's one of our biggest challenges.
Mm-hmm. Yeah. How about any successes?
Oh, I think that, well, let me see. I feel like a lot of us here, some of the faculty that's been here much longer than I have, we felt like when we received the HRSA BWAC grant a couple of years ago, we felt like that was recognition for the work that, the foundation work that we'd been doing, or that they've been doing for so many years. And so being recognized and being given the opportunity to build on that, I think that's been really wonderful. We have a lot of our graduates that have gone on to and have careers in integrated primary care and specialty care, and so we're really proud of them, and kind of makes us feel like it's worth it. That kind of having this special kind of quasi specialization in our program is worth it, and that we're doing our part to build up that workforce.
Mm-hmm. Thank you. Victoria, what are some of your successes and challenges in your work?
Sorry, I had to do the same thing. I found the mute. I've also stopped my video because I saw no one else is using it. So I was the only face, I think, on the call. But some of the challenges I've had have been related to trying to define roles. And again, you have to almost, it's a little bit different. I don't know if there's any medical people on the call, but the nurse practitioners are very similar to the primary care physicians. And so challenges are, having the nurses work to the highest level of their scope of practice, nurse practitioners. And that means that they have the ability to utilize other members of the team they need to learn to utilize other people on the team to do the screening, to do the interpretation of the screening, and then feel comfortable either bringing in a behavioral health consultant if they're lucky enough in their practice to have one, or, to know what to do when they have a positive screen. So, I'm working with individuals in rural areas. So typically there aren't behavioral health consultants. And if they do get them, it's learning how to integrate those folks. The other challenge that I have is with behavioral health consultants that they don't necessarily, they feel like they have to have somebody on their schedule in order to have patients seen. And that's been a struggle with some of the FQHCs that I've worked with. Like they'll tell me that they have only 2 patient encounters for a whole day, the behavioral health consultants. And so the challenge has been trying to get the teams to work together. My role is not teaching the behavioral health consultants, but rather teaching the nurse practitioners how to work to the highest level of their scope of practice, and then also how to embed psych nurse practitioners into primary care. And that's primarily when there is not a behavioral health consultant, or when there's a need for a psychiatrist, but there isn't a psychiatrist available. And so then they are able to help with medications as well as brief therapy. So those are, I have lots of challenges, but those are the two big ones that I can think of.
Okay, how about a success?
There's lots of successes. And so in our most recent project that we did, in again, using a full team and having everyone work to the highest level of their scope of practice, we have been able to show, we have 2 years of data showing that a massive decrease in opioid prescribing. And this is because the psych NP that was embedded was able to educate the primary care providers how to recognize depression based on the screening, of course, but also what medications to use, which then the person had a positive response and then even remission and did not need their opioids. So that was a huge success. So a lot of ours are patient outcomes, and then also seeing people get back to work, which is another very positive outcome. And also trying to get people to work, together and seeing teams actually be cohesive.
Mm-hmm. Thank you so much. CR, how about we go with you and then we'll go with Stacy.
Okay, so first of all, just a kind of a step back from our conversation so far, I just really appreciate this conversation because what we're identifying is we're all trying to train people at varying levels depending upon where that person is in their development as a clinician. And so when we think about challenges and successes, they're going to be really different from one to the next because of the level of training and experience that the various students we work with is so varied. So I just wanted to acknowledge that. It really helps to think about how all of us are working toward the similar aim, but we also have different struggles that we encounter and have to address. Absolutely. On ours, all of our folks are licensed folk, and so when they go into a site, that's something that breaks the barrier down. The sites are willing to have someone who is licensed because they know they have the supervision and everything else prior to even getting there. The challenge that arises is that we're noticing more and more as we work with our sites that, and this is just really a reflection of the field, is that integration takes on so many different forms. So we are focusing on the key elements of integration, focused primarily in primary care, but when our students actually go out to a site, it could be in a variety of different settings and a variety of different models could be used. And so the challenge that has really arisen, it's like, I'll give you an example. We're working with Mayo. We have some students there, and they have a particular model they've developed for integration. And the setting in which they are trying to establish that model is one in which they have a firm commitment and value to address someone's needs across the whole scope of whatever those mental health needs might be. And so in a typical primary care site, you might refer out for mental health, but they want to provide the continuum of care right within their own site, even with someone with an SMI. So that has stretched us and challenged us. Okay, well then what does that mean for our students? And practically it means that some of the time the students are there, they do have to have those 50-minute sessions because there are some patients that are going to need the intensive psychotherapy to manage their mental health condition. The reason I mentioned that as an example is because prior to encountering that, I was really reticent to students doing more than 20 to 30 minutes for a session and even have a metric that monitors that. And that has caused me to rethink that a little bit, so that what ends up happening is that there's enough room for that student to address the need that the site needs to address. And yet at the same time, the remainder of their time, they should be available for warm handoffs and brief targeted assessments and interventions for the other patients that don't need nearly the level of care that those other few do. So that's been a challenge. Another challenge that I have encountered is with our largest health system in the Phoenix area, Maricopa Integrated Health Services. They are trying to address those who are in really high need areas of the city. And so the social determinants of health are just numerous for those patients. So it's causing them to really consider how that medical team is able to fully address the range of the determinants of health. And so the students are placed in a position where they can't simply just do the typical targeted assessments and interventions that I mentioned, but they also have to really increase their skills to bring the members of the team who can also address some of these broader issues, not just the medical issues with the medical team. So those are two that have come up in the last few months, actually, in our arrangements with those two sites. They're two important sites. And so it really caused us to rethink, how do we help guide our student, keep them on track as to what integrated care is and the necessary components of providing good care, while at the same time being flexible for the kind of model that the site might have. On the success side, oftentimes what happens is that a student will go into a site and they're somewhere, they have some kind of model somewhere. If you use the SAMHSA's levels, they're somewhere along that continuum. And when the student is involved with the medical team, demonstrating what they can do with patients, and even more so, training the medical team on the issues related to the comorbidities of medical and behavioral conditions and ways that the medical team can engage with those patients around behavioral issues while remaining at the top of their license. It really helps to reinforce this idea of a team effort, team responsibility, a team that really embraces the overall health outcomes of those patients. And we've had many students who have then been hired on to direct their integrated services because they see the value of this person coming in who has this skill set, who has not only transformed the day-to-day operations in terms of their involvement, but has helped to really lead the practice toward a transformation, toward a higher degree of integration.
Great, thank you so much. So I will hear from Stacy on this point, and then we can move, just for the sake of time, into our question and answer period. So if you have a question, you can either click the raise hand button at the bottom of your window, so I know to call on you when Stacy is done with her answer, or you can send me a chat with your question by double clicking on my name, and I will read it out to the group. So thank you, Stacy.
Sure. Just to echo what's been said already, there's definitely been some shared challenges. I think for us, it's been the identification of internship supervisors, clinical supervisors who have experience supervising in primary care. And so we have a lot of supervisors who train in mental health settings, they're using supervision models in those settings, which is fantastic. But in primary care, it's a lot different in how you supervise students. And so that's been a challenge. And a lot of the feedback from our trainees over the years has been, please give us supervisors who have either trained in and supervised in primary care, please. And so because of that, we've added some additional supervisor workshops throughout the year that, as part of a role of being a supervisor, attending those workshops quarterly to learn supervision styles and models for medical settings. So that's been an area for growth for us. I think one of the great things is that just hearing from a lot of our sites that are new to integration, hearing from them that they don't see themselves functioning without behavioral health, where it's really been embraced as just a standard for primary care. And so when we do our end of the rotation site visits, hearing that from our sites over and over has been just really encouraging, especially on the times when it seems like there are more problems than good things. So hearing from the sites about that has been great.
Yeah, that's great. You know, it really resonates with me what you mentioned, Stacy, about that challenge where, because it's something I think about too, is sort of how are we supporting these efforts through supervision and just sort of having on-site folks either when, sort of as Florencia mentioned, you know, within a graduate program, you often do other things. And so maybe you don't have as many people who, like you were saying, have either had experience in integrated primary care or have had the unique experience of supervising in integrated primary care. Or also in sort of brand new settings, right, who are new to integrated primary care itself, and maybe they don't have someone on site to sort of support those efforts. So that's something that's very interesting to me. So are there questions that anyone has? Feel free to click the raise your hand button, or you can also, like I said, chat your question to me and I will read it out to the group. While I'm waiting for that, I think, you know, so a question that I am interested in as someone who is sort of training folks at the graduate level for their first, usually their first sort of mental health degree, is what are some of the skills, those of you who are interacting with sort of students at later levels of training, what are some of the skills that you sort of would like graduate level training to sort of emphasize as they're preparing students to step into these integrated primary care roles, either at internship or postdoc or work-wise?
This is Stacy.
Mm-hmm.
I would say if graduate programs can somehow add curricula or modify curricula or something like that that encourages comfort with uncertainty and flexibility. And so whether that means moving away from the traditional lecture-based approaches to teaching and using things like team-based learning or some other teaching strategies that encourage thinking outside the box and dealing with complexity, I think is an invaluable skill. Well, it's a great life skill, but I think it is even more helpful in primary care when that's essentially what they're dealing with a lot of the time. I see a lot of students struggle who are pretty inflexible and rigid. And I see those students struggle a lot versus students who kind of welcome kind of anything goes type approach. So. Right.
And so I'm picking up that you feel like that's a training thing and not a temperament thing.
Yeah, I mean, I think some of it's temperament and some of it can be taught as well. So I think there's been some research on curricula that's been redesigned to encourage those skills, at least in medical schools. Mm-hmm. And so I think as for behavioral health, we can definitely catch up in at least curriculum redesign to train our folks to kind of meet those same demands that our medical colleagues are doing, which is being comfortable with uncertainty and flexibility, just in general.
Yeah. Victoria, looks like you have your hand up.
I do. I was going to add to that one of the things I've found is useful, and again, I do appreciate what you all are saying, that I am sort of the black, I don't know what you want to say, the odd duck out here, in that the folks that I'm training are actually also learning to prescribe and how to manage care as nurse practitioners. But, you know, our issue certainly has been in beginning training is using simulated patients, which is a great way to watch and see, again, how students learn So I even did a project where I looked at, again, those tabula rasa students and videotaped them with a simulated patient, and then, looked at them before they left the program, even before, and really helped them to see how they had changed. So that was one sort of strategy that we could actually identify if someone wasn't flexible, like you were saying.
Mm-hmm.
Or like I even had one student that answered the phone, their cell phone went off while they were being, videotaped. And so we were able to talk about that. But that's a really great strategy for helping students learn across time. And having the ability to videotape them is a great way that they can see how they changed.
That's a great idea. Yeah. CR, as someone who sort of trains folks who are often sort of further along in their career, what are some of those things that you've noticed that you would like sort of maybe students to be a little further along the spectrum?
One thing that was coming to my mind as I was listening is that there's, when you have, as in our case, a program that has people all over the U.S., and so that means preceptors in a number of different sites. And then we assign faculty members to work with small groups of students as more in that supervisory kind of role. They're really, we have to think about what are the targets that students should hit while they're on that site, and then what kind of guidance can we provide that preceptor to look for those targets? Because in many cases, we obviously don't have the benefit of working with a small group of sites that are closely, in geography to us, and that we know them really well. We have to work with ones with a lot of variability and a lot of different types of settings. And so I chatted to you all a copy of the evaluation form that we use that I developed in order to help us to really, all of us to be on the same page. The program, the faculty members working with the student, the preceptor who's working with the student and observing that student's work. What I did is, about 3 or 4 years ago, I basically took all the lists of core competencies that I could find, did a crosswalk of all those to try to find, there are some overlaps, and do any of those offer any guidance in maybe some other areas. And so I ended up developing this evaluation form that tries to really hone in on those targets. And then I ran this by people like Chris Hunter and Jen Funderburg and others to say, hey, I know you've been working in this area a long time, can you provide some feedback? And so through a process of kind of iterative process, developed this evaluation form. As you can see with the gray bars, it has various domains and then specific items or knowledge or skill areas for each domain. And then behavioral anchors, things that the student would be doing. As you'll notice under the column focus evaluation, that's the part that's really helpful to that site person who is looking for guidance on where would I see this occur. Mm-hmm. So that offers them some suggestions for where they might see each of those various activities demonstrated by the student. The other thing that I did with this is you'll see in that third column called dimensions, I want to also correlate each of the items with the three worlds, because I want to make sure that the student is thinking both clinically and operating both clinically and also operationally on all of the items. I want them to continually demonstrate that they understand clinically what to do, but also do they understand the business that has to be sustainable and the operations that need to be effective and efficient as they do their clinical work. So this evaluation form is intended to guide and direct the student to think about what they could be doing, the preceptor to evaluate the students doing those things, and then of course all of us who are working with the students. So I hope that answers your question, but I think it gives at least something to focus on, is at least a tool that's been helpful to us.
It does, and I appreciate you sharing this with all of us. I think it's really useful.
Yeah, and I'd love to hear any feedback if something doesn't make sense or something seems to kind of rise above and beyond. I'd love to hear that. Not necessarily today, but if anybody has any comments, I'm certainly open to those.
Wonderful, wonderful. Any other questions or comments on what we've been discussing so far?
It seems to me, I'm just going to throw out an idea.
Sure.
That I think our intent is that this will be an ongoing conversation. It's not just a one-time thing.
Yes.
I really have appreciated hearing about all that everybody's doing, and it would be quite interesting to kind of do a compare and contrast and maybe even write that up at some point, because I'm sure there are a lot of people out there that could benefit from hearing how each of us in our own ways have worked things out, and the types of issues that have drawn us towards certain strategies versus others along the way. So anyway, I'd just throw that out.
Yeah, no, I agree. I think that would be a really useful thing. I would love to read that. I think that would be very useful. So yes, what I will say sort of to CR's point is we do hope that this conversation will continue. So we have talked a little bit about maybe having either a formal or informal meeting at the conference this year. So if it's formal, it will look like a sort of discussion table at lunch on one of the days that anyone would be welcome to come and join and meet everyone in person and sort of continue to talk about graduate education, integrated primary care. And then informally would just sort of be more, folks who are interested in finding each other and getting together and sort of having these conversations, which we'll probably do anyway. So I really want to take the opportunity to say thank you so much to our volunteer panelists. I really appreciate you taking the time to do this and share your knowledge and your experiences. And thank you everyone to coming in for this discussion panel on a late Thursday evening. So I appreciate it. And if there aren't any other questions, then we'll go ahead and sign off. I can stay for a little bit in case anyone has any additional questions or anything like that, feedback, anything like that.